Welcome, neighbors, to the series we have named Talking with the Doctor. On the surface, it seems a simple thing. You visit the doctor, you tell him or her what's wrong, or what you think is wrong, or at least what is troubling you. He or she listens, nods, makes a few notes on the computer, asks a few questions, and proceeds to tell you what you need to know and what can or will be done to eliminate the problem. It sounds simple and routine, but it isn't. That first presentation of a health problem is very, very important, and there is never enough time for it these days. All too often, one or both participants in the conversation fail to make the best possible use of that too short time. That is what we hope to discuss and illustrate in this series of episodes, each of which features a healthcare issue or a major medical specialty. We'll talk about the problems of communication in each field. We invite you to join us.
Dr. Paul Gross is a former, that is to say, a retired academic. He was professor of biology at MIT and at the University of Rochester, and the Taylor Professor of Biology at University of Virginia, where he was also the provost. And he was, for 10 years, the director of the MBL, the Marine Biological Laboratory in Woods Hole. Ellen Curran is the practice manager for the medical center at Linden Ponds in Hingham, Massachusetts, and she is also a regional practice manager at the Erickson Foundation of Baltimore, Maryland. Sandy Peavy, a Linden Ponds resident, is an attorney and member of the bars of Maryland and the District of Columbia. Her baccalaureate is from Cornell, and her law degree is from Duke University. Sandy, who continues in legal work while semi-retired, is also deeply involved in television as the crew chair here at LPTV6 and in the larger world of regional public access television.
We've explained to Paul today the forms he should prepare in order to make sure that his doctors understand his wishes, even when he cannot communicate them himself. But doctors themselves sometimes use forms to communicate important information to patients. To be sure that their patients understand this information, they ask the patients to sign the forms. Most often, these forms are called consent forms. You will be asked to sign one whenever you enter a medical facility for an invasive medical procedure, such as surgery. You may be given the form while you are being prepared for the procedure. It may seem as if you don't have time to read it carefully, and it may appear at first glance to be routine boilerplate, comparable to the software agreements we sign when we download new software to our computers. But it is not. It contains important information about the risks to you of undergoing the procedure. You should already have discussed these risks with your doctor. But whether or not you did, take the time to read the consent form carefully before you sign. And ask questions if there is anything that you don't understand. Just as the forms we discussed with Paul today are one more way of talking with your doctor, consent forms are just another way of talking with your doctor. This program is one of a series of episodes concerned with something we all do, talking with the doctor. We would like to leave you with this thought, that once you have completed the forms that we discussed with Paul today, the healthcare proxy, and the living will, you, your family, and your doctor will feel great relief. Thank you for watching and listening, and accept our best wishes for your health.
Hi, Sandy. Thank you so much for coming in today.
Well, thank you for having me. It's nice to be here.
It's going to be a pleasure. We have a wonderful gentleman who has a lot of questions today about advanced directives.
okay.
And in fact, I see Paul now. Hi, Paul. Thank you so much for coming in this afternoon.
Hi.
Paul, this is Sandy. Sandy is our expert
Hello,
on
Sandy.
the legal issues of advanced directives.
I'm all ears.
It's your favorite topic, I know.
Yes, I love it.
I know. Well, you have a lot of questions
I
and
do.
a lot of concerns, and
I do.
Sandy's really going to be a great advocate to help us today.
I'm
Okay,
glad
I hope
to-
I can answer all of your questions so that you'll go away feeling very comfortable, at least about the legal forms. It's not about your health.
Sandy, I've been waiting to talk to a lawyer about this for about 5 years. So
All right, so
I'm
today's
all
the
ears.
day.
And-
So let's dive in, and let's really talk about the most important document, the
Right.
healthcare proxy.
Right.
Okay, let's take a look at the form, because the form is what you start with, and as you can see, it's not necessarily all self-explanatory. The meat of the form is in paragraph 2, which kind of looks like it's fine print, so I'll go over that with you. It starts out, my agent shall have the authority to make all health care decisions for me, including decisions about life-sustaining treatment, subject to any limitations I state below, which you would write in the form. Okay, you're
I got
all
you.
right there.
I got you so far.
Okay. But who's your agent? Have you picked out anybody yet?
No, I have not, and that's one of the reasons we're talking. I want to know about that.
Okay, you need, because your agent can make all of these decisions for you, you want to make sure that it's someone that you trust.
Yes.
Could be a relative, could be a close friend, someone that you feel confident will make the decisions that you want to have made.
And Paul, also someone that's been advised that they are your healthcare proxy.
I can
Yes.
see. I can see that. Yeah.
Well, a lot of times people won't tell people they've made them their healthcare proxy, and that's very important so that you know that.
Yeah.
Right.
Okay,
Okay.
I've got that.
But your agent's authority doesn't become effective right away as soon as you do this. My agent's authority becomes effective if my attending physician determines in writing that I lack the capacity to make or communicate healthcare decisions. So only if you can't make these decisions yourself will your agent be making
Okay,
them for
so
you.
there's a secondary decision involved. I make the decision, if I were doing this,
Right.
I make the decision about who will be the proxy, who will
Right.
be
Yes.
represent, who will be my agent.
Right.
Yes.
But the physician makes a decision about whether that agent is qualified.
No,
No.
not if the agent is qualified. You,
Is
whether or not you are able to make your own healthcare decisions.
I see. Okay.
If the physician says that you're not able to do that,
Then the agent.
then the
is qualified.
agent kicks in.
Okay.
And
I
the
got
other
it.
thing, Paul, to understand with a healthcare proxy is there are times that you may have something happen where you've had surgery and the anesthesia's made you where you are not of the ability to make decisions. They'll invoke the healthcare proxy for a couple of weeks, and then when you cleared, they'll re-invoke the healthcare proxy that you're now of sound mind. So it's a living, breathing document.
Yes, it changes depending on the state of my cognition.
Yes.
Exactly.
Yes,
Exactly.
exactly.
Okay.
That raises a question about
Okay.
distance. I'm thinking, as you're saying all these things, that for somebody like me, superannuated type, you might want to have a proxy who is nearby. who is close
Well,
enough?
yes, I would say yes, but I would also say the big thing is that the person who's your healthcare proxy knows your wishes, and we'll go into that even further a little
Sure.
later on.
Okay.
But it's really most importantly that the person understands that they are your healthcare proxy and what your wishes are. They become your voice.
Right. And if you have a healthcare proxy who may not be available
No.
all of the time, or maybe at a little distance, you can have an alternate healthcare proxy named in this document.
Okay.
And if your agent, we call them agents as well as proxies,
Yes.
cannot be there when you need them, the alternate,
alternate
can step
is
in and make
empowered.
those decisions.
Yeah.
Yes.
What I was really thinking about was naming as proxy a child who happens to live in California, a child who would be the most trustworthy person. But you've solved the problem. If there can be an alternate
Right.
Right,
who can serve in an emergency.
right.
Right.
Okay.
And I think, Sandy, it's really important for us to also explain what makes an active healthcare proxy.
Yes, and we'll go through the form. Look at the form again. You see at the very top up in the corner, be sure to fill in your birth date, and then you put your name and address, and then comes the name of your healthcare agent and that person's address. But then you can see after the term optional, there
Yeah.
are 2 more lines. That's where you will put your alternate name and address.
I see that now.
Okay,
Yeah.
and then you sign under 3 where it says signed. But, and this is extremely important, it must be dated and it must be witnessed. Okay, number 4 is the witness statement, and that's where the date occurs. So it has to be dated there under 4. You see where I'm pointing? And there are 2 places for witnesses. You need the name of the witness, their signature, their
And
address, and the name of the second witness. And it can be anybody. It does not have to be notarized, just witnessed by 2 people.
I see.
And don't sign it yourself until you're in the presence of those 2 witnesses. So you can fill all this out before you go to have it witnessed, but then you, just as if you were having it notarized, you wait and you sign it and you date it at the time the witnesses sign it also.
Okay.
Okay?
I got that.
Now- Got
I have a last
And
question.
the other thing also is if something changes, the reason that the date is so important is you can change your healthcare proxy at any time. If something happens and you really want to have somebody different or something's changed in your life, that's why the date is so important. So that document is a living, breathing document that brings us really into now, I think Sandy really wants to talk in a little detail about a living will.
Right.
Oh, I want to talk about that too. I don't
Good.
know what it's about.
Yeah. It's not like your will where you bequeath your possessions.
That's the only thing I know about it. It's
And-
not really a will.
And while the Massachusetts form for a living will is titled Living Will,
Yeah.
it's really an advance directive, and that's really a better name for it, which where you're giving your directions in advance for what you want to happen to you if you become very seriously ill and you cannot make these decisions for yourself, or you cannot communicate them.
Okay.
And you'll notice at the bottom of the healthcare proxy, it says that you direct your agent to make healthcare decisions based on my agent's assessment of my personal wishes. Now, this is where the living will comes
Okay.
in.
Those are my personal wishes.
Yes.
In the living will, that's where you express your personal wishes. So let's take a look at the living will form. I've brought a very general form of a living will, but they can be pages and pages because you can be very specific in this document. And
Yeah.
again, you notice this does not even have to be witnessed. You just have your name up at the top, your address, your instructions in the middle, and at the bottom, your signature, and again, the date. The date, again, is very important for the same reasons we just talked about with the healthcare proxy, because you can change your mind and you can change what's in the living will and do a new one, but date it again so people will know the most recent one.
To whom does this document go?
Well,
Okay.
I think the most important thing on all of your documents is that they stay with you, they stay with your healthcare proxies, whoever you've named, and they go to your providers, your doctors, because they need to know as well what your wishes are, so that if your healthcare proxy is invoked and we're talking to your agent, we know also what your wishes are, so that we can make sure that your voice again is still being heard.
But this implies that there really does have to be a single doctor, a designated senior provider. Let me phrase it differently.
Yep.
In difficult circumstances for people who are in bad physical health,
Yes.
nowadays there are likely to be a panoply of physicians and providers hanging around.
It's always your primary care physician.
Okay.
My practice here at Linden Ponds is with primary care, and when something happens, we work with all of the specialists. All of the information, I call it the wheel. We're the middle of the wheel, and the spokes go out, but everything comes back to that inner wheel.
Yes.
So for us, it's important for us to have all of that information so that we can advise and help and make sure that
Okay.
things happen.
The PCP is the person.
The PCP
who
is
gets
the
this thing.
the driver. Yes.
Okay.
Very much so. Not in, and we don't put them in a safety deposit box so no one can see them. They live and breathe. They stay where people can access them.
Okay.
And you
Good.
should do the same thing. You should keep it in your apartment with you. You shouldn't
course,
put it in
of
your
course.
safe deposit box.
Of course.
Either
Right.
of those. But let me go over just a little bit. This particular living will form is very simple. And I'm going to go over this part of it, but then I'm going to ask Ellen to explain some of the things more specifically that could go in it. This says, should a time come when there is no expectation of my recovery from physical or mental disability or disease, I direct that I be allowed to die with dignity, and that my doctor withhold or withdraw treatment that merely prolongs life and is unlikely to offer a cure or remission of the disease. I direct that treatment be limited to measures that will keep me comfortable and relieve pain. Now, you could do something that is as simple as this, but nowadays there are so many different things that doctors will consider doing to
Yes.
you, for you,
Yes.
to try to make you better as opposed to just relieving pain and making you comfortable, such as putting tubes down, breathing tubes,
Yes,
and
yes.
and such. And I asked Ellen to describe some of these things. You can put all of these things in here and say what you do and do not want. But let's let Ellen tell us what they are.
So, yeah, you're right, Sandy and Paul. I have seen living wills that are 1 page. I've seen living wills that are 10 pages. Some people are very specific. They may not want a feeding tube, or they may not want to be intubated. There's many options, and you can go as specifically as you want. I mean, there are some people who have genetics in their family that there's certain things that they know that if this happened, they wouldn't want. So again, it's really personal. It's a document that's your personal beliefs of what you want to have happen. But the biggest thing I also want to stress again is that this is when you can't make the decision. Any time that you are aware and something happens and you have something that you want to change and you're the cognitive ability to do that, you can do that in real time, and these documents do not live.
Yeah,
So
okay.
it's almost like the most. Massachusetts has a new form out that's called medical orders.
let's take
And
a
let's
look at
put that one
form.
up,
Let's
Yeah,
because
see.
that's
I've heard
a very
about that one.
interesting one.
Yes.
And
I've
it's a
seen
very
that.
new form that's come out through the state, and it's actually a medical order. When you go to the doctor and you have to go to the hospital and get an x-ray, they give you an order. And you go in and they do the x-ray or the CAT scan. This is the same type of a document. It's a living order from the provider that states your wishes, whether you want to be intubated or you don't want to be intubated, whether you want to have CPR or you don't. And so you have made decisions with your doctor, your healthcare provider. This is the only way that document can actually be activated. And it lives with you and it agrees with you, and you can take it and another provider will honor it, as long as you also want it honored. So again, it's something that You can help to make decisions if you don't have the capacity to do that. But if you still do and things change, you also have the right to make changes in real time.
Even though I'm thinking of myself now as the patient.
Yep.
I hate to do that, but
Well, you need to. Right.
even, I want to get this clear, even if I have decided that I do not want cardiopulmonary resuscitation to be done, in a moment of madness, I make this decision. And it gets put down on this page. Suppose at the last moment I change my mind.
And you're of sound,
And
clear mind.
And my
trump.
PCP thinks that I am. So
You trump.
it's not a joke.
No, I'm very serious.
Yeah.
You have the ability at every moment of you're cognitively sound to make any changes that you want.
And in fact, let's assume that it's a matter of whether you're going to be resuscitated. So we'll assume that you have lost consciousness. But last weekend, you were having dinner with your healthcare proxy, and you said, you know, I signed these papers and said that I didn't want to be resuscitated, but you know, I'm having second thoughts about that. I'm not so sure that that's what I really want. And you have a discussion. And then, lo and behold, you're in this situation. Your healthcare proxy will be invoked because you're unconscious. That person can override this most
I see.
and
Yes,
can make
I see.
that decision for you, because remember, the healthcare proxy can make any decision you
And
could
Sandy,
have made.
didn't that happen with your father?
Yes, yes. My father recently passed away at the age of 99.
Good
And
for
when
him.
he was 98, he said to his doctor, you know, I've had a long and a happy life, and I don't want you to be giving me this resuscitation and stuff like that. And so I want you to know that if my heart stops, it means it's the time for it
What
to
a
stop.
guy.
So, but then he went into the hospital with some atrial fibrillation or some kind of fibrillation. His heart didn't actually stop. He was awake. He knew he was under some duress. His heart was under some duress. But his doctor was just not responding. He didn't come in on a Sunday. His doctor, of course, thought, oh, well,
we'll just let
you
him
know,
go.
we'll just let him go.
I got a story when you were
But
finished.
he insisted, and they got the heart going again, and he lived very happily for another good part of a year. So,
I have to share one with you.
okay.
Dear friend, old friend of mine, who was a distinguished child psychiatrist and so on, reached an advanced age and fell and was injured and was recovering very slowly. So the doctor, her doctor, who was an old family friend, gathered her children together, the three of them, and said to them, now, let's be serious. I don't think she's going to make it back. I see the beginning of systems failure and so on. Would you like me to make efforts to keep her alive, or shall we let her die quietly
Right.
with dignity
Yeah.
if the need arises? And the children were terribly upset about all this, obviously, but adults they were, and they said, okay. This is a true story. So he went to see our dear friend Lee, and she was awake and in her hospital bed, and he said, now look, Lee, I've been talking to your kids. And she said, yeah, they've been hanging around. And he said, this is serious. We are talking about measures to be taken if your condition continues to deteriorate.
Right.
And they have pretty much decided that you should be allowed to go in dignity, that we should not make extraordinary efforts. So, Lee, what do you think about this? And she said, do everything.
See, her voice trumped.
and she lived for 5 more years.
See? So that, I think that really sums up what we're saying. Is no, it's so true. And I think that's what, hopefully, we've answered your questions and made you feel more comfortable about the process.
Very much so. I've been hearing about and actually have been involved with these forms for a long time, but I've never actually had anybody tell me what And of course, reading them out of the question.
Yes.
Right. Yes.
Well, I want to really thank you all so much. It seems like our time is almost up, dear friends. And thank you, Sandy, so much for being here and helping us. It was a priceless moment
was
to
my
have
pleasure.
us.
I
Thank you.
enjoyed it.
Thank you so
Thank
much.
you.
So this completes our second episode of the series, Talking with the Doctor. Please watch and join us for more episodes to follow. They're all important issues, and it's all about good communication between the patient and the doctors. We have upcoming series on specialties such as psychiatric medicine, anesthesiology, surgery, geriatrics. And this is, I think, one of my passionate ones as well, is drug safety and effectiveness and what is really important. So we welcome your participation with us, and thank you for having us today.